Well, welcome everybody to Optometric Education Consultants National Webinar Series, Tuesday night edition. Our topic tonight is the sebaceous gland link, integrating dermatology into ocular rosacea and MGD care with Dr. Kaleb Abbott. He's an assistant professor at the University of Colorado School of Medicine. He's a faculty member in the Dry Eye Clinic and the Center for Ocular Inflammation, where he specializes in complex ocular surface disease and contributes to clinical trials and research in this field. He serves on the board of directors of the Ocular Wellness and Nutrition Society and is the vice chair of the Nutrition, Disease Prevention, and Wellness Special Interest Group for the American Academy of Optometry. He also contributes to the Academic Medical Center Optometry ALSIG Advisory Council as a member of the editorial board for Optometry 360. In recognition of his many contributions, he was nominated for Colorado's Young Optometrist of the Year in 2024 and was named one to watch by Modern Optometry. So with that, please, a nice virtual, warm OAC welcome, Dr. Kaleb Abbott. Kaleb, please take it away.
Thanks so much, Joe. So tonight we're going to go into essentially trying to connect dermatology with eye care. And this is something that I think helps shed a lot of insight into conditions like ocular rosacea and meibomian gland dysfunction in general. So I'm excited to give this lecture today, and hopefully people get a lot out of this and you can think about these conditions a little bit differently. These are my disclosures, all of which have been mitigated for this talk. So the first part of this, for the first hour, we're going to lecture really on facial rosacea and ocular rosacea. And then the second hour or so, we're going to go into how to approach MGD as a sebaceous gland disorder. We'll start with facial rosacea before we go into ocular rosacea. So we've known that facial rosacea is a big problem for many, many, many years. In 1387, in Geoffrey Chaucer's book, The Canterbury Tales, where the summoner, or a character in this tale, was described for his facial redness. They even blamed his facial redness on drinking of strong red wine, and even were trying different treatments at the time for his, what is we now know is facial rosacea. So things like mercury, lead, brimstone, borax, arsenic, ointment, and cream of tartar. This is a painting from the 1480s during the period of the Italian Renaissance. It's entitled An Old Man and His Grandson, and it's by Domenico Ghirlandaio. And you can clearly see in this painting that the old man has rhinophyma. He's got a certain type of facial rosacea. If you look carefully, you can see he's got some puffiness of the eyelids as well, and his cheeks are a hair rosy too. So we've seen facial rosacea depicted in paintings a long time ago. This is not a picture of rosacea at all. This is just a painting that I really like called Abraham and Isaac by Rembrandt. But Rembrandt also painted self-portraits. So what you see here on the left is a self-portrait of him whenever he was young, believed to be in his 20s. And then you can see a self-portrait of him whenever he's older, probably in his 50s or 60s. And you can clearly see he's gone on to develop facial rosacea. You see kind of the puffiness and the red nose, and then you see kind of the classic rosacea signs of the redness of the face going from ear to ear. So from tragus to tragus, all along there, which is exactly where we're also trying to treat whenever we do IPL with our patients. So we'll go first into facial rosacea. So facial rosacea has commonly been referred to as the curse of the Celts. It's most commonly found in persons of Northern European ancestry. However, it's important to know that 4% of rosacea patients actually have dark skin complexion. I have patients that are not classic phenotype for ocular rosacea. I have patients of Africa, so it's not just Caucasian patients like a lot of people think. So there's a genetic component, a microbiome component, environmental components, and it's estimated that only 18% of persons that have facial rosacea are actually utilizing any treatments for their facial rosacea. They're largely just trying to avoid triggers of rosacea. So facial rosacea is most commonly found, though, in persons with fair skin, blonde hair, and blue eyes, middle-aged, they're age 30 to 60. Facial rosacea affects women more than men, but ocular rosacea actually does not have any gender predilection. It affects people equally. And then there's a genetic predisposition to it also. This is a heat map of the prevalence of rosacea in the United States. You can see that certain states have more rosacea than other states there. You can see that there's a little bit more concentration in the Northeast and some of those Midwest states. And this is really believed to be mostly due to people's ancestries and ethnicities. The prevalence can be as high as 14 to 15% of Caucasian women, a worldwide prevalence of about 5% of the population, 10% of the Swedish population. And we know that facial rosacea affects at least 16 million Americans, but that number is a gross underestimation of the number of patients that have facial rosacea. The main reason that we know that is because most patients with rosacea don't actually go and see a dermatologist and don't actually seek any care for their facial rosacea. They simply know that they have it, or maybe they might not even know that they have it. They just know that certain things will cause their face to turn red or trigger symptoms of irritation. If we really want to see where facial rosacea is growing, we can look at where the money is flowing. So this is the growth rate by region. So we see that North America, there is some growth, but surprisingly, actually, Asia Pacific is having the most growth of anywhere in the entire world. So that kind of goes along with the fact that, again, this is not just people of Caucasian descent, not just people of a lighter skin complexion, but can affect people with darker skin complexion too, which we're starting to learn. So the pathogenesis of rosacea and ocular rosacea is complex. So here's a few statements that are definitely true about facial rosacea. It is a neural disease where vasodilation is greater and more persistent. There's also an autoimmune component where the body is overreacting to certain triggers, and this causes dermal inflammation. Telangiectasias, or these kind of dilated superficial blood vessels, form, and then in later stages, you can get fibrosis and hypertrophic scarring as well. If you ask maybe 10 people that have facial rosacea what facial rosacea is, you'll get 10 different answers. And that's really because there's so many different things that are happening here. Some people will say, well, it's a condition that if I'm exposed to certain triggers, my face turns red. And that's true. Other people might say, well, it's a vascular condition or a neurovascular condition where the blood vessels dilate too much. And that's true. Some people point out the skin barrier dysfunction that's seen, kind of with the sebaceous gland dysfunction. That's true. Some people describe it as a microbiome problem on the face and in the gut. That is also true. Some people go and talk about genetics or oxidative stress or stress to the blood vessels and inflammation. And all of that is true. And for this reason, facial rosacea and ocular rosacea is hard for people to wrap their heads around and understand. It's also why we see so many different treatments for facial rosacea. And it can be confusing because you might have 5 patients come into your office that have facial rosacea. They're all on 5 different treatments for their facial rosacea. And you're thinking, well, how can that be true? Because there's so many different things that are going on. But what rosacea is not, is it's not purely an endocrine problem or bacterial. It's not purely Demodex, not purely environment, genetics, or skin complexion. It's really a mixture of many different things happening to these patients. And the best treatment per se is really the avoidance of triggers. And this is evidenced by the fact that only 18% of patients that have facial rosacea are actually on any prescription therapy. So most patients will have triggers to things like spicy foods, which you've all heard of, or red wine. So foods that are high in histamines can cause problems. Alcohols, the climate is a really big one. Sun exposure, extreme temperatures, changing temperatures. So if it's really hot, if it's really cold, if you keep going back and forth between a hot environment and a cold environment, windy days bother these patients. Strenuous exercise, anything where you're getting vasodilation. These patients are greatly affected by things like stress, lack of sleep, anxiety, stuff like that. And then most of these patients end up having some sensitivities to certain products like fragrances or skincare products. And men's products are notorious. They oftentimes contain things like menthol or eucalyptus oil or peppermint oil or things like that. So these are the most common triggers that are associated with facial rosacea. We don't have this exact same chart for ocular rosacea, but we assume that it's pretty similar to this. By far, the number one is sun exposure. So sun exposure is the most common thing that will trigger facial rosacea in our patients. Then emotional stress and lack of sleep, hot weather, wind, and heavy exercise. Interestingly, the things that we think of most commonly, like alcohol or spicy foods, are actually a little bit further down the list. Only 52% of patients that have facial rosacea report alcohol as a trigger, and less than half of patients actually report spicy foods as a trigger. It's only 45% of these patients. So by far, sun exposure is the most common trigger. So, and when we're talking about sun exposure being a trigger, we're really talking about UVB light. So UVA light penetrates deeper into the skin. It's absorbed by the dermis. It causes aging and wrinkling. But UVB light is what is absorbed a little bit more superficially, right where all of those superficial telangiectatic blood vessels are. And the UVB light will stimulate angiogenesis or growth of new blood vessels. It'll stimulate dilation and spreading of those blood vessel roots. So one thing that you'll see a lot of confusion on when it comes to dermatologists, and dermatologists even disagree with other dermatologists on this, is what is the difference between facial rosacea and just chronic sun damage to the skin. And you'll see some patients, maybe we're told by one dermatologist, oh, it's rosacea. Another dermatologist says, no, it's not rosacea, it's just sun damage. So this is because sun exposure over time ends up mimicking rosacea because it causes that angiogenesis. The big difference between chronic sun exposure and rosacea, though, if you're trying to differentiate the two, is that there should be triggers when it comes to a patient that has facial rosacea. There should be something that exacerbates it. So maybe it's the alcohol or the spicy foods, or maybe it's stress or things like that. That should make it worse. And that's really how you differentiate the two. There's also a pH concern in these patients. So in general, our skin is slightly acidic. So we have a pH of our skin of about 5.4. One reason for that is our sebaceous glands actually secrete sebum that is slightly acidic, and this is trying to ward off pathogens from sitting there and kind of dwelling on our skin and causing infections. But a lot of the products that our patients are using, like soaps and skincare products, they have a pH that's either neutral or even slightly basic, and that can exacerbate facial rosacea in a lot of these patients. So this brings us to our first polling question. Which of the following is the most common trigger of facial rosacea? Spicy foods, alcohol, sunlight, or stress?
All right, the polling question is open. For those who are on phones, kind of look for that polling question. Those that are on a computer, on the right side there, you can see the polls. People found them. They're starting to roll in. Yeah, so I like to point out is when you see the person with the rhinophyma, that isn't a person that has developed rosacea just overnight. That's really a great sign of chronicity. And when you were showing that picture, that wasn't something that just happened. It's kind of, I kind of think of it as a callus, all that chronic low-grade inflammation, and that skin just keeps on thickening. So for the audience that's out
Yes.
there, when you see rhinophyma, that isn't something that just, happened, 5 or 6 weeks ago.
And that one does have a gender predilection. That one does affect. And we're about to go into the 3 different types of facial rosacea before we delve into ocular rosacea.
Okay, so I think we've got a pretty good poll here. So I'll display the answer. We got 3% saying spicy food, alcohol 5%, 4% stress, and the clear winner at 88% is sunlight.
Wonderful. Glad people are listening. I feel like if people weren't listening, a lot of people would say spicy foods because I feel like that's one of the most common ones that we hear, that and alcohol. All right. So we will continue. Now,
Kaleb, if you put that first, you probably would have got that as spicy food and alcohol.
I think you're probably right. Yeah, because that's always the ones that people talk about. People don't really talk about sunlight, even though it's by far the clearly the most common trigger. So
And
now we're
it's
going to go
the
into
sunlight, just to recap, you said it's the UVB, just to kind of, is that
yes,
correct?
it is
Okay.
the UVB. Yeah, because it's UVB is absorbed a little bit more superficially. Those of us who do IPL, we all know that the setting that you're using affects how deep into the skin it's actually going, and so you're targeting certain blood vessels or different parts of the dermis and epidermis whenever you're using different types of filters. So it really matters how far and how deep the light is penetrating. So we've all seen different patients with rosacea that have different appearances. So we're going to go into the three different types of facial rosacea. Now, classically, we've heard that there's four types of rosacea. So the four that are listed here, the first one's the hardest one to say, erythematotelangiectatic, papulopustular, phymatous. Those are the three facial types. And then there's ocular, which was considered the fourth type, but this is starting to be phased out because we now realize you can have ocular with any of these types of facial rosacea or on its own. So it doesn't really make sense to call ocular its own distinct type of rosacea and say that there's four types. There's really three facial types and then one ocular type. So the first one we'll talk about is erythematotelangiectatic facial rosacea. This is the one that I think a lot of us classically think of as vascular rosacea. This is a patient that has prominent redness of the face, kind of ear to ear and all over the nose. This persistent telangiectatic blood vessels, they dilate. They're located on the central face. There's a neural and a vascular component, both of which are hyperactive. This is classically the patient that we all knew in high school, that we all knew kind of the boy or the girl that would blush really, really easily, that maybe he or she would get embarrassed. And when they would get embarrassed, it would lead to the face turning really, really bright red, or they would eat certain foods and the face is really bright red, or they go outside in the sunlight, face bright red. Well, over time, that redness stops going away. It used to be that it would kind of occur transiently in response to triggers, but then over time, that face starts to now have more and more and more background and baseline redness to it. So the blood vessels start to spread, they start to take root, and you start to get this increased background redness in the dilation of these blood vessels. So it goes from being a transient blushing, like in high school, to all of a sudden now a persistent redness of the face. Now, the second type of facial rosacea is papulopustular rosacea. This is what is called acne rosacea. So a lot of times, like if we're looking up ICD-10 codes, we don't see papulopustular, but we see acne rosacea listed there. This is due to inflammation, not exclusively, but there's a lot of inflammation present. And 80% of these patients actually have demodicosis or Demodex of the face. So we all know about Demodex blepharitis of the eyelids. Well, we see that this happens of the face as well. And the type of facial rosacea most commonly associated with Demodex of the face is this papulopustular or acne rosacea. So typical acne treatments don't really work well for this. Vitamin A derivatives can actually worsen this. This can cause thickening of the skin. Now, one thing that's interesting with this is it presents later in life than typical acne. So when it comes to typical acne, we're thinking about patients that are adolescents. We're talking about, people that are teenagers, that they have this spike in testosterone that's happening around those teenage years. So they start to get increased production of their sebaceous glands, which we'll talk about more in the second half of this lecture. And then the bacteria that's on the face, you end up getting these plugs that form, and then the bacteria ends up causing an infection, and that's how you get a little pimple that's present there. But what we're talking about here is not acne in adolescence. We're talking about this happening suddenly in the middle of adulthood. So why would you be getting acne maybe in your 40s or maybe in your 50s? Well, the reason for that, it's thought that your immune system is slowly decreasing over time. And the Demodex of the face that naturally reside there now start to become a bigger problem. And they start to clog up those glands more. They start to lead to more of a problem. You're not fighting them off as well. You're not fighting off the bacteria off your face as well. And that's why you get this adult onset of acne. So it's not typical acne, completely different pathophysiology than adolescent type acne. This responds well to sulfur, which and Demodex treatments, which are known to kill Demodex, and then things like azelaic acid, which are vasoconstrictors that can help out with the inflammation. And then the third type of facial rosacea is phymatous rosacea, which we've talked about a little bit. This is also called oil gland rosacea. In this case, we see kind of a disfiguring appearance. So these glands just keep growing and growing over time. You start to produce more and more and more sebum over time. You get skin thickening. It gets kind of greasy looking. And in late stages of this, you start to see fibrosis and kind of thickening along the nose, like you see in the pictures there. And this really do prescription options as well. This responds much better to surgical management. So Thomas Bateman in 1812 said the perfect cure of acne rosacea is in fact never accomplished. Kind of like dry eye we know that there's not really a cure for it. When it comes to facial rosacea, we are simply trying to manage it. This is a problem that the patient has that's really an anatomical problem. It's an anatomical, and it's an autoimmune problem. They have all these extra blood vessels, and things are going to trigger those blood vessels. So all we can really do is try to slow it down, try to control what's going on and all of the other manifestations of it, but we can't really cure it. So here are some over-the-counter treatment options that I like to kind of just keep this list of to give to my patients that I suspect have facial rosacea, or I know that they have facial rosacea, but they're not really getting good treatment. So there's certain products that work well. Things like niacinamide, that is helping with kind of the mitochondrial health of the skin, as kind of an anti-aging properties in that. We have chromium oxide greens. So green is on the opposite side of the color wheel as red. So it's thought that if you use chromium oxide greens, this will cancel out some of the redness if you were to use it in like a facial moisturizer. There's things like caffeine and azelaic acid that are vasoconstrictors. If you constrict those blood vessels, the redness is less apparent. So I try to keep kind of just a list of these over-the-counter treatments around just to tell my patients. Now, if we look at the prescription options that are available for these patients, this is where it gets super confusing because we see that there's so many different things out there. We might have a patient that comes in using metronidazole, another one that comes in using Retin-A, another one's using ivermectin, another one's using oral doxycycline. There's so many different options. That's because you can tackle facial rosacea in many different ways. You can do topical antibiotics like metronidazole. You can do oral antibiotics like doxycycline or azithromycin, and that can help with the bacterial component. It can help with kind of the skin microbiome component, but those are also strong anti-inflammatories as well. That helps with the inflammatory component of facial rosacea. There's things like Retin-A. Retin-A is trying to decrease sebaceous gland activity. If you decrease sebaceous gland secretions, it's less likely that those glands are going to become clogged and lead to some of the lesions and kind of the pustules that these patients can get. Because there's so much inflammation, you see that steroids are used. Because there's Demodex, we see that topical ivermectin is used. There's really just so many different things that patients end up using here. And it's funny, if you talk to some dermatologists about ivermectin, they'll say, yes, we use ivermectin, but it's not really for the Demodex. We do it because it's a strong anti-inflammatory. So I think in eye care, we disagree with dermatology a little bit on the role of Demodex. They don't think it's that pro-inflammatory. We believe that Demodex really is very pro-inflammatory. We believe, probably, if you were to ask most people here, they would say that they would believe that ivermectin would work for facial rosacea because you kill the Demodex that are leading to inflammation. And then there's surgical, there's light-based therapies like IPL, and laser-based therapies as well. One of the most common things that we see for acne is Accutane or isotretinoin. That's a very, very, very potent vitamin A derivative that decreases sebaceous gland activity, also decreases meibomian gland activity, which we'll talk about a little bit more in the second half of this lecture. So this brings us to poll question number 2. What type of facial rosacea is most associated with demodicosis or Demodex of the face? Is it the erythematotelangiectatic or vascular rosacea, papillopustular or acne rosacea, phymatous or oil gland rosacea, or granulomatous inflammatory rosacea?
Okay, the polling question is open. Joe, is there any questions?
No,
Or
we're
are there-
good.
Or are there any questions?
We are good.
All right, this one's a little bit slower. This is like a boards question here. So this one's taking a little bit of time to roll in. So all right, we'll let this one, it's rolling in slow, but we got some answers. We got the trend happening here. So I'll display the answer. And we've got 9% going with vascular rosacea, 63% is your winner at acne rosacea, 17 with oil gland rosacea, and 11 with your inflammatory rosacea. So you might want to explain that one a little bit since it was a little bit lower at 61.
Yeah, so again, this is really the adult onset acne cases. When we see demodicosis, we're talking about acne that's forming in adults, but it's not forming due to the same reasons that it happens in kids. It's forming because, well, we believe because Demodex are clogging up those sebaceous glands and leading to them getting plugged up, and then the bacteria associated with kind of the changes in the microbiome lead to an infection there. So you start to get kind of this adult onset of plugging of those sebaceous glands. And then answer choice D, I just tried to, there's not a granulomatous type of rosacea. I just tried to come up with something that sounded like a real name for a rosacea. All right. So I think we will get more questions once we move to ocular rosacea, because not a lot of us are treating facial rosacea at this point. But when we go over facial rosacea, it gives us a really good background for what is happening with ocular rosacea. And there's a lot of confusion when it comes to ocular rosacea. If you ask dermatologists, they'll say about 20% of rosacea patients initially present with ocular rosacea. They'll say facial rosacea almost always precedes ocular rosacea. If we ask people in eye care, they'll say that up to 90% of ocular rosacea patients have minimal skin findings, and that ocular rosacea is found in up to 75% of rosacea patients. So in general, dermatology does not think that ocular rosacea is very common. They think that facial rosacea is common, but ocular rosacea is not common. So what is ocular rosacea? When we think about what facial rosacea is, it's very similar signs. The number one sign is going to be that lid margin telangiectasia. So we are seeing these telangiectatic blood vessels all over the eyelids. When we think about the anatomy of the eyelids, we are supposed to have blood vessels there, but these blood vessels are supposed to be deep. They're supposed to be deep. You're supposed to see one every now and then. They're not supposed to be superficial. So we're not supposed to be able to easily see them kind of right underneath kind of the most superficial aspect of the epidermis. And there's not supposed to be a lot of them. If you look in this bottom picture here, there's a lot of these blood vessels, and they're going all the way from the eyelid margin. They're coursing all the way to the lid margin themselves, like you see in both of these pictures. They're actually coursing in between meibomian glands. There's a meibomian gland orifice right here where my laser pointer is, right here, right there. And we're seeing that these blood vessels are coursing right in between those meibomian glands. And this is one reason that we start to see a lot of MGD associated with ocular rosacea, because you start to get inflammation, you start to get compression of the meibomian glands because those blood vessels are inflamed and taking up space right next to those meibomian glands. So you can start to get MGD, you can get reduced meibomian glands yielding a liquid secretion, thickened meibum, a rapid tear breakup time. You'll start to get blepharitis. Just like you get inflammation of the skin, you're going to get inflammation of the eyelid. When we get inflammation of the eyelid, that we call that blepharitis. And again, because the meibomian glands are housed inside of the eyelids, we can start to get meibomitis as well, inflammation of the meibomian glands. You can get some lid margin erythema, just like you can get redness of the face, conjunctival injection, and saponification. So saponification is when we see the frothiness of the tear film, kind of some bubbling of the tear film. And that is really thought to happen due to you having too much bacteria that's present on the eyelids. Those bacteria have these things called bacterial lipases. Lipases break down lipids. So when the meibomian glands are secreting oil onto the ocular surface, we see that the bacterial lipases are breaking down that oil. And when that happens, it leads to frothiness of the tear films. We call that saponification. And that's evidence of an altered microbiome of the eyelids. When it comes to symptoms for these patients, I've always thought of blepharitis kind of as the great masquerader. And ocular rosacea really is the great masquerader as well. You can get really any symptom under the sun: irritation, foreign body sensation, grittiness, burning, redness, tearing, pain, fluctuating vision, light sensitivity. This one's interesting because we believe that some of the branches of the trigeminal nerve that go to the eyelids, when they get irritated, it's actually projecting along the trigeminal nerve to areas of the brain that are responsible for light sensitivity. And this is why we think you can have light sensitivity with blepharitis. It's also one of the top reasons that in our dry eye clinic, our number 2 referral source of our dry eye clinic is our uveitis clinic. Our uveitis clinic gets all these patients that are urgent add-on cases for light sensitivity. They take a look, they say that there's no iritis present, they see that there's blepharitis, and then they send them to our dry eye clinic. And then these patients can also get chalasia, hordeola, and styes too, because we're getting clogging up of the pilosebaceous glands of the eyelashes, and then also the sebaceous glands of the eyelids, which are the meibomian glands. And then the altered microbiome can lead to an infection. So you can start to get kind of that painful hordeola. So what's happening here on the eyes? Well, this is an exaggerated response of our innate immune system. You get increased toll-like receptor 2 expression. This increases something called CLK5, which doesn't really matter what that is, but in the end, this produces something called cathelicidin, and cathelicidin does matter. So whenever we're getting this inflammation, it's leading to the production of cathelicidin. Cathelicidin is normally only produced in response to pathogens, to try to ward off pathogens and fight them. But in cases like this, you start to get cathelicidin that's produced in response to normal environmental stimuli or triggers, so spicy foods, sunlight, stress. And what this ends up doing is it increases VEGF release. So now everyone is kind of back and knows what we're talking about here. So we all know what VEGF is. VEGF, we talk about this with the retina all the time, how it can lead to neovascularization in the retina in cases like macular degeneration. So if cathelicidin increases VEGF release, well, then we can start to get blood vessel growth on the eyelids. We can start to get neovascularization, but not of the retina, not of the iris, not of the trabecular meshwork, but of the eyelids themselves. So we start to see this increase in VEGF release on the eyelids. This produces telangiectasias, dilated blood vessels, and just like neovascularization of the retina and the iris, these are not healthy blood vessels. These blood vessels are bad, they're pro-inflammatory, they increase inflammation, and they cause problems. We also believe that increased VEGF release can also spill over onto the conjunctiva. Potentially, you can start to get increased blood vessel density of the conjunctiva, which is why a lot of these patients come in and they're complaining not of discomfort, but of redness of the eyes because they physically have more blood vessels on their conjunctiva that's leading to their eye looking red, even though those blood vessels may not be dilated. There's just a lot more of them. And in severe cases, you can actually get corneal neovascularization and limbal stem cell deficiency and things like that. But these blood vessels, I told you before, they're coursing between those meibomian glands that are causing inflammation. You can get meibomitis. We all know that blood is warm. So when you get all of this extra blood flow to the eyelids, it creates warmth. That warmth itself is what is encouraging microbes. It's encouraging increased bacteria to live there. It's also encouraging Demodex to live there as well. So downstream from ocular rosacea, we get all of these different manifestations. We get things like meibomian gland dysfunction. We get pure film instability, ocular surface inflammation, dry eye. We get that altered microbiome, Demodex blepharitis, hordeola, chalazion, styes, conjunctivitis, keratitis, dermal edema. We can even get things like allergic conjunctivitis because we know that patients can be allergic to bacterial byproducts, but also Demodex byproducts. So in those cases, patients start to get itchiness of the eyes, which is why one of the most common symptoms of ocular rosacea is itchiness, because you can start to get this kind of allergic conjunctivitis. And it can get pretty bad. This is incredibly rare, but you can get cases where you start to get corneal neovascularization, corneal scarring. You can get inflammation along the limbus that causes limbal stem cell deficiency, neurotrophic keratitis. One of my favorite patients, we thought for the longest time that she had ocular cicatricial pemphigoid because she developed a symblepharon, like you see right here, connecting that eyelid to the bulbar conjunctiva. And she had this cicatrizing conjunctivitis like you see down there. Then we realized after doing a biopsy that she did not have OCP. Really, she just had severe ocular rosacea that was leading to all this inflammation and changes to her conjunctival anatomy. And it can lead to entropion, ectropion, and the most severe cases, corneal ulceration or perforation. But we can't talk about ocular rosacea without mentioning Demodex blepharitis. So Demodex are these eight-legged arachnids that are present on the ends of their 8 legs. They've got claws. They crawl into our meibomian glands. They crawl into our pilosebaceous glands. So we can have Demodex of the face, which we talked about with papulopustular rosacea, but you can also get Demodex of the eyelids as well. And they're oftentimes related. So we see that patients with facial rosacea, and just like they have of the face. So it causes a folliculitis and inflammation, and it doesn't respond well to typical treatments. So the top Demodex that's pictured here is a species called Demodex brevis. This is a shorter, fatter species that lives inside sebaceous glands, like the meibomian glands. And the bottom one is Demodex folliculorum. This is a longer, skinnier type of Demodex that lives inside pilosebaceous glands. So the sebaceous glands that have hair follicles, like our eyelashes. So these Demodex are light averse, so they really crawl into the glands during the daytime. They crawl out at nighttime to have a little mite party. They breed, they lay eggs, they have a good old time, cause all sorts of problems. That's why a lot of our patients will wake up in the morning with irritated eyes because they've been out there partying all night and doing their thing all night long. Their life cycle is about 3 weeks. Females lay 15 to 20 eggs once. And something I do not recommend telling your patients is that they can crawl 1 centimeter per night. So we believe that even if you were to treat Demodex blepharitis of the eyelids, that if you don't get rid of the Demodex of the face, then potentially they could then crawl from the kind of hair follicles on the cheeks or on the nose and actually get back to your eyes, which is why you can get a recurring Demodex blepharitis. And the way that we tell what Demodex blepharitis is we see these collarettes kind of at the very base of the lashes. The collarettes stay at the base of the lashes because there's something inside that pilosebaceous gland or that hair follicle that continuously is producing that collarette. And collarettes are composed of waste products, dead epithelial cells, keratin, lipids, and egg products. So, poll question number 3. So we talked about lots of different manifestations that can happen with ocular rosacea, lots of downstream effects that can happen. Which of these is not a potential manifestation of ocular rosacea? So we have meibomian gland dysfunction, Demodex blepharitis, chalasia, hordeola, styes, bacterial conjunctivitis, allergic conjunctivitis, or herpes simplex keratitis.
Hey, Caleb, as those are rolling in, question came in. Can you explain again what is the link between photophobia and blepharitis?
Yes, this is the presumed link. You can't find a lot of information on why blepharitis triggers photophobia, but the leading guess is that your trigeminal nerve branches into your eyelids, so it's innervating the eyelids, and it's believed that if you get inflammation of those eyelids, that ends up triggering action potentials of the trigeminal nerve endings inside the eyelids that then is traveling along the trigeminal nerve and eventually to brain areas that are responsible for light sensitivity. Because we do know that the trigeminal nerve, when it enters into the brain, it doesn't just go to places that are responsible for eye irritation, but it goes into areas of the brain that are responsible for light sensitivity too. So this is why we think that blepharitis can lead to a photophobia.
Very good.
Any other questions, Joe?
There are none.
Okay. So I'm going to display the answer, and we have basically 1% going with Demodex blepharitis. We have 2% bacterial conjunctivitis. Allergic is 5%. The clear winner at 92% was herpes simplex keratitis.
Great. This is going better than last time when I gave a lecture for y'all and every choice was like 20%. So yes, herpes simplex keratitis is not associated with ocular rosacea that we know of. But the interesting thing about ocular rosacea is that it leads to so many different things that we commonly see all the time. There's so many different things I could list here. I actually listed like 10 before if you can get patients that have recurring bacterial conjunctivitis, you would say, well, how could that be linked to ocular rosacea? But it can, because if you have changes in the microbiome of the eyelids, these patients can continuously then get a bacterial conjunctivitis. But again, a very common symptom of ocular rosacea is allergies, because you're allergic to some of the bacterial exotoxins, or you're allergic to those Demodex byproducts. So we get these referrals into our dry eye clinic, and the referral will come from an outside optometrist or ophthalmologist and say, this is just a disaster patient. Like, this patient's got chalasia and hordeola, they've got meibomian gland dysfunction, they have blepharitis, they have dry eye, they keep getting bacterial infections, they've got allergies, and they're like, this is just a disaster of a case. And we take a look at the patient and we say, well, there's really only one thing that's happening. That's ocular rosacea. And then the patient has all these downstream effects. And when, these patients come in, they say, why is all this happening to me? If you can give them a clear-cut answer and say, it's really the ocular rosacea, and explain why, these patients are very appreciative of that because it really helps them better understand what's going on. It also helps you frame your treatments when you understand that you don't have to be treating 6 different things. You could really just be treating one thing. So that leads us into conveniently treatment.
Let me make one comment before you move on, because
Sure.
we all have in the last few years, which is really cool. We're starting to learn about the gut microbiome, and we have prebiotics, postbiotics, the importance of the good bacteria, so on and so forth, the diversity of bacteria. And, we got to think of this when you're seeing these patients that are coming in with these recurrent styes and conjunctivitis and Demodex, that what is upset is the lid microbiome. And you were talking about it, that we have, certain pHs and so on and so forth. So, I want the audience to kind of think that, just as important that there's the gut microbiome, we have a normal flora, a normal lid microbiome, things just like medications in glaucoma, the BAK can disrupt that by killing off maybe the good bacteria and allowing those, and the pH changes that can occur. So when you see these conditions, just think about, I want the audience to realize, to think about is, in this discussion, is the lid microbiome is disrupted.
Yeah, that's totally true. We know in cases of rosacea, we know in cases of Demodex blepharitis, that these patients have a shift from commensal or good bacteria to pathologic or harmful bacteria. So they don't just have more bacteria, which they do, but they have a shift towards bad bacteria in general. Okay, so when I think of ocular rosacea, I try to figure out what I think is causing the most problems for patients, because there's so many different aspects for what can happen. So when we go over treatments, we're going to go over how to treat inflammation, how to treat the MGD, how to treat the blepharitis, how to treat the dry eye. So some of this, there will be overlaps between these. So in general, if I have a patient with ocular rosacea, I'm always prescribing a topical immunomodulator. There's always inflammation with ocular rosacea. So I'm prescribing a cyclosporin, or I'm prescribing a lifitegrast. Oftentimes, I'm prescribing them a topical corticosteroid too. Sometimes they take this topical corticosteroid long-term. That's pretty rare because we know that there's long-term consequences and side effects of that, but usually I'm giving this to them for flares. So they're on a topical immunomodulator twice a day, every day. Then they use a topical corticosteroid to bail them out of flares, because we all know that rosacea and dry eye, you have flares. So they might do like a fluoromethalone or loteprednol, twice a day for 3 to 5 days in cases of flares. You can also, potentially the patient may need something stronger, like a antibiotic steroid drop that's maybe got a dexamethasone in it. That's why you'll see a lot of these patients will come in. They'll be like, oh, I've used Tobradex, or I've used Maxitrol for these flares. I keep getting this infection or this redness, and that someone keeps prescribing them a strong antibiotic steroid, that they use it, it goes away, then it comes back. They use it, it goes away, it comes back. When we use a steroid, we're weakening the local immune system. So if you weaken the local immune system, you can make Demodex blepharitis worse. You can make the bacterial component of this worse too. So we don't want to use steroids unless we really have to. So I do some oral antibiotics, oral azithromycin or doxycycline, but I prefer to do topical azithromycin. There are studies that show that topical azithromycin works just as well as oral doxycycline, but with less side effects, and probably works a little bit quicker. So I do topical azithromycin for these patients. Sometimes I'll just do twice a day for a month. Sometimes I will, if they get flares a lot, I'll do twice a day for 7 days, take a few weeks off, twice a day for 7 days, take a few weeks off, twice a day for 7 days. So it's like a Z-Pack for the eyes. The first week of each month is oftentimes what I do. And then IPL is very helpful for inflammation. There's also likely a role for vasoconstrictors, like over-the-counter bromonidine. In eye care, we never think about vasoconstrictors as a treatment. We think about it as for cosmetic benefit. But in dermatology, they think about vasoconstrictors as a treatment all the time. They prescribe prescription azelaic acid for rosacea. Why can't we use vasoconstrictors to treat the inflammation associated with ocular rosacea? I think that we can. So
Hey,
if the
Kaleb,
patient, yeah.
With all the changes in the cyclosporins that are out there, Restasis started off at 0.05%, and then Sun went with the micellular type of delivery. I was never a big Restasis because it was a fat-loving molecule that was hard to get to the tissues. I would tell them to use, 4 drops a day just to kind of help force it in. And then Sun came out with Sequa and increased the percentage to 0.9%, 0.09%, and changed to micellular. And then we have, Vivi with Harrow right now, and they're at 0.1%, changing their mechanism of delivery. Are you finding, do you have a preference on percentage with one of these molecules, since there's been a change in this whole kind of cyclosporin arena?
Yeah, I will say in general, I think the stronger the better in cases like this. I do use the 0.1% cyclosporin for this quite a bit, and I do have quite a bit of success with that. Um, Lifitegrast is a great molecule. I use this for a lot of patients. When it comes to ocular rosacea, for reasons that are a little bit unclear to me, I seem to get better results with cyclosporin than I do lifitegrast, but I do not know why that is.
Yeah, so lifitegrast, to remind everyone, that's Xiidra that kind of works on the surface of the cell, maybe because you're getting inside the cell and hitting that cytokine release. Maybe that's kind of maybe the mechanism. I'm just kind of spitballing off the top of my head. I agree when it comes to ocular rosacea, the cyclosporin definitely shines with over the Xiidra or lifitegrast. But in dry eye, quick results, typical dry eye, see that Xiidra works. It's why it's good to have this lecture here to kind of separate it out.
Totally.
Good. Perfect.
Um,
Thanks.
so if they have blepharitis, MGD, hordeola, there's things like lid hygiene, there's oral omega-3s. These patients, we do not want to be recommending warm compresses. This is kind of the one subset of patients that we don't really want to do that. They already are prone to inflammation. They already have too many dilated blood vessels. When we put heat on that, it in general makes things worse. I think it's important with our patients like this, like ask them, when you use warm compresses, does it actually help? If it's not helping, then don't have them use it. I'll have them sometimes do a hot versus a cold compress trial and see which one they think helps them the most. And a lot of times they'll come back and they'll say that the cold compresses help a lot more than warm compresses. So again, because it's not just about the meibum, it's about what is happening to the eyelids. So topical azithromycin can be so helpful in cases of the blepharitis, the MGD, the hordeola here. IPL is extremely helpful in these cases also. You can do blepharoexfoliation, thermal pulsation. I do a lot of IPL with these patients. If they have a lot of scarring, keratinization over the lid margin, I do meibomian gland probing sometimes in these cases too. Just a fair warning, if you do that, they will bleed because there's a lot more blood vessels there. You're going to nick a blood vessel. It's not a big deal, but just be prepared for that. And then we now know that lotilaner, so Xdemvy, is helpful not just for Demodex blepharitis, but we do know that it improves meibomian gland dysfunction in the setting of Demodex blepharitis too. So by treating the Demodex blepharitis, you can improve not just the Demodex and the blepharitis, but you can also improve the meibomian gland dysfunction. And then if they have keratitis, if they've got dry eye, topical immunomodulator is very helpful. I have a theory that these patients can become aqueous deficient because there's so much inflammation that you get inflammation that's backing up to the lacrimal glands, the glands of Krauss and Wolfram. And in those cases, like where you get severe dry eye associated with this, autologous serum eye drops. So eye drops made from their own blood are very helpful. Corticosteroids can be helpful. I do not do punctal plugs ever in an ocular rosacea patient. In my experience, at best, it does nothing, but usually it worsens things. Oral doxycycline, sometimes these patients require scleral lenses, and that can be very helpful for them. The gold standard for ocular rosacea is IPL, though. This is a treatment that came out of dermatology and treating of facial rosacea. It is highly effective in ocular rosacea. It is the only treatment we have that is directly targeting the actual problem. This is the abnormal vasculature. It's sealing off those telangiectatic blood vessels through vascular thrombosis. It improves everything. It improves inflammation, MGD, lid margin telangiectasias, Demodex, the bacterial overload. It can improve blink mechanics, and it can also help with the cosmetic appearance of the eyelids and sometimes even the bulbar conjunctiva. So IPL is really the gold standard for cases of ocular rosacea. In the future, we may have a drug that is coming out next year that's a RASP inhibitor. This is like a very potent anti-inflammatory. We will know in December, I believe December 16th, if it is FDA approved. There's a company that's working on a topical lotilaner for the eyelids for cases of ocular rosacea. That certainly could be helpful. Then there's brimonidine drops can be used off-label. I have a lot of my ocular rosacea patients use the over-the-counter brimonidine. Vasoconstrictors for the eyelids, I've got a couple patients using azelaic acid or brimonidine gel on their eyelids. And then I do a lot of compounded facial treatments for these patients too, especially if they keep getting recurring Demodex blepharitis or they have untreated facial rosacea. I like to do a compounded treatment with ivermectin, metronidazole, and azelaic acid from a compounding pharmacy. It's about $40 for a tube, and a tube lasts 1 to 2 months. And that can be really beneficial for kind of the downstream ocular rosacea that's happening. And there's also lifestyle changes that patients can make. So eating foods that are high in omega-3s, anti-inflammatory foods, prebiotics, probiotics, limiting alcohol consumption, prioritizing sleep, and then of course, sun protection in these cases. So in summary from the rosacea part, ocular rosacea is common, but it's commonly missed. It's prevalent in cases of facial rosacea, but it can occur in cases without facial rosacea. Symptoms can be non-specific, but the manifestations of ocular rosacea are widespread. And even though we don't have a single FDA-approved treatment for ocular rosacea at this time, we have plenty of options to help these patients out. So I think if you start looking for facial rosacea in your patients, I think you will find that so many patients end up having facial rosacea. So if you're listening and not looking at the slides here, these are some pictures of patients, of people that we know have facial rosacea, people like Bill Clinton, Cameron Diaz, Princess Diana, Rosie O'Donnell, Prince Williams, W.C. Fields, J.P. Morgan. There's many patients that have facial rosacea. There's many patients that have ocular rosacea if we start to look for it.
Hey,
So
Kaleb, before we move
Yeah, Joe.
on, we had a couple of questions come in.
Okay.
Does hypochlorous acid have any role here?
Yes, hypochlorous acid, it can be extremely helpful in ocular rosacea when you see that saponification. So you have the increased bacterial overload of the eyelids. So anytime I see that, I'm recommending a hypochlorous acid. It's important to recognize that hypochlorous acid kills bacteria. It can help the microbiome of the eyelids. It does not kill Demodex, but it does kill the bacteria that's associated with Demodex. So you may be able to indirectly improve Demodex by affecting the bacteria that live with the Demodex, but it's really mostly for bacteria.
What is your dosing treatment regimen for doxycycline for MGD?
Yeah, I don't do a lot of oral doxycycline anymore. I used to do a lot of it, but since I found a place that can compound topical azithromycin, I lean more towards that now. But if I were to do oral doxycycline, I mean, I would usually do 50 milligrams once a day for 90 days. And you might say 90 days sounds like a long time. I mean, you can do 30 days. In my experience, if you did the 90 days, it worked a lot better than the 30 days and it seemed to last longer. And some people will do 50 milligrams twice for 30 days. To me, you start affecting the microbiome at that point. So I like to do that lower dose of 50 milligrams or even 40 milligrams. Very helpful.
Hey, a couple more questions. What's the dosage of Lumify that we use? Twice a day?
That's a good question. I don't think I necessarily have something that I'm recommending to patients specifically. If you ask an ocular rosacea patients how long Lumify lasts for them, the average patient with dry eye would say 6 hours, maybe 8 hours. The average patient with ocular rosacea will say like 2 hours or 3 hours or maybe 4 hours. So you will need to use Lumify probably more frequently with an ocular rosacea patient. One thing to keep in mind is that Lumify, that the one that is preserved, it's preserved with a BAK. So in these patients with ocular rosacea that end up getting dry eye, which is almost all of them, it's best to do preservative-free Lumify. And if you take a patient that's on preserved Lumify and you just switch them to preservative-free Lumify, they notice a tremendous improvement in how their eyes look and feel. So we should really only be recommending the preservative-free Lumify. And if we are recommending the preservative-free Lumify, to me, there's not really much of a restriction on how many times a day you can use it. Like I'd be fine with patients doing it 2 times, 3 times a day. I think that that would be fine, even though the bottle probably says once a day.
Well, we got to consider the fact that glaucoma patients use a higher concentration 3 times a day for years
Yes,
for monitoring.
exactly.
Couple more
Yes.
questions. Is azosite still used, and is cost an issue?
Azosite is still used, and cost is a giant issue. So because of that, it's not really still used. So I use, if you find the compounding pharmacy Imprimis RX out of New Jersey, so that's Imprimis RX, they have a product called Clarity A. So it's Clarity with a K, and the A stands for azithromycin. And a patient can get a 3.5 milliliter bottle of that for, I believe, about $40, which is dramatically cheaper than azosite is. So in general, I have my patients just go to Imprimis RX and get Clarity A.
And how are you writing for the compounding of ivermectin, metronidazole, and azelaic acid? What's the dosage?
Yeah, so that's actually a product from a company called Skin Medicinals. And Skin Medicinals is a compounding pharmacy in New York, I believe New York. And they have a product called Rosacea Triple Cream. And this product is incredible. Like if you have patients that can't get into a dermatologist, or you just want to start them on a treatment prior to them seeing derm, or a patient that just won't see a dermatologist, this product works so well, and it's super affordable. I honestly don't even know the concentrations of all those 3 different ingredients because it does it for you. So it's just a product called Rosacea Triple Cream from Skin Medicinals. And I prescribe this all the time, and my patients really love it. A small fraction of patients, maybe say 20%, they get irritation with azelaic acid. In that case, you can reformulate the product to take azelaic acid out, and you can add niacinamide in. And in that case, it still works really, really well, and there's less irritation. So keep that in mind. And I would usually have patients do that just at nighttime, kind of all over their face, and even some on their eyelids too. Sometimes I'll have them do it twice a day.
And here's another question. In terms of a alternative to long-term doxycycline, what is your thoughts on, for glandular disease and rosacea, a gram of azithromycin once a week for 3 weeks?
A gram of azithromycin once a week for 3 weeks. Yeah, there are studies that have looked at that. They've looked at a gram at different time periods. And I would say, in general, I'm shifting my mindset to be more in favor of azithromycin over doxycycline. So we actually call this azithromycin pulse therapy. That's kind of what you're describing. And so you can do a gram, every week for 3 weeks. You could do a gram, the first day of each month for 3 months. We don't really know what's best. There's not enough studies out there comparing all of this. Or you could even do just a Z-Pack. You could do a Z-Pack essentially the first week of each month for 3 months. I most frequently am doing that. So instead of doing the 1 gram, typically I just do a Z-Pack the first week of each month for 3 months. But personally, I find that that's very beneficial for my patients. And I've kind of shifted away from doxy a little bit more towards azithromycin. And I've been getting, I wouldn't say it's dramatically better results, but I do feel like azithromycin works a little better than doxycycline.
Yeah, that's the dosage I've been doing the pulse 1 gram a week for 3 weeks.
Okay, you do that.
It's easier on the patients. They don't have the long-term use and some of the issues they might have with doxy.
Oh, that's good to know. And it's affordable, I presume. Is it affordable?
Oh yeah, it's very reasonable.
Okay, that's good to know. Yeah, maybe I'll try that.
Let me make a couple comments regarding the doxycycline, just to kind of, that are out there that usually roll in when I do a live lecture, is that I just want to make one comment about, at the higher levels, 100 milligrams once or twice a day, that's kind of an antibiotic, maybe your
Mhm.
MRSA type of treatment. So that's why we're going to recommend the lower dose, 50 milligrams. And that will kind of think of it as an anti-inflammatory, a steroid that's out there. So
Yes.
for those listening, the lower dose,
Sorry,
think
I
of
don't
it more
understand.
of an anti-inflammatory, and a steroid higher dose, 100 milligrams twice a day, treating Lyme disease, treating MRSA. So kind of go lower, longer. Then the other question that usually comes up is it's the difference between monohydrate and hemihydrate. Really nothing. I always use the analogy. It's kind of like vodka drinks. It could be vodka orange juice, vodka cranberry. It could be ginger beer. It's just the delivery. It doesn't really affect. Some are in capsules and tablets. Sometimes they're in back order and not. So it doesn't really matter in the hemihydrate or the monohydrate. Just make sure it's around 50 if you're going to do the kind of the low dose.
Yeah, totally agree. Yeah, the that 50 milligrams is supposedly subtherapeutic when it comes to the bacteria. So because of that, you don't get as much GI issues. So yeah, you're mostly using it for inflammation at that concentration.
So I think another comment that I would make, because of your azithromycin kind of pulsing every, the first of the month, you're giving kind of 3 weeks for that gut microbiome to kind of regenerate, right? So,
Hmm.
the doxycycline kind of low dose doesn't really touch maybe because it's kind of subtherapeutic, but you're probably killing some bacteria in the gut. But that kind of like that you know, 1 week on, 3 weeks off to give that gut microbiome a little time to heal.
Yeah, and I mean, if you don't mind going through the extra work to get compounded topical azithromycin, I really do believe it works pretty much just as well in a lot of these patients, and you don't have to worry about the gut microbiome at all at that point. So I find that's a
Exactly.
good option. It's just it's a little bit of a pain to go through the compounding pharmacy. All right, so we're going to move on now to how we can think about meibomian gland dysfunction as a sebaceous gland dysfunction. So we're going to go into sebaceous glands and then go into meibomian glands and how they're similar, how they're different, and how we approach treatment of MGD kind of from the viewpoint of a dermatologist. So sebum is a Latin word meaning tallow or rendered fat. So if anyone in the audience barbecues, you know how you take a brisket that's got this kind of horrible fat on it that's typically an untenable piece of meat, and you slow cook it for such a long time that that fat slowly renders and it becomes really juicy and moist and nice and actually kind of flows, and instead of being really really hard. That's kind of originally what uh, people were thinking of when they were seeing sebaceous gland secretions. They were thinking that this is an oil, but it is a less viscous oil. It's something that's able to flow. It's kind of like a nice oil as opposed to a hardened fat. So, and we have sebaceous glands located throughout the skin of our entire body, except on the palms of our hands and the soles of our feet. And there's two different types of sebaceous glands: pilosebaceous glands associated with a hair follicle, and free sebaceous glands. And that is what the meibomian glands are, a type of free sebaceous gland. So this is the anatomy of a sebaceous gland. This is important for us to kind of understand for how it works. So we have a central duct. Coming off the central duct, we have an alveolar duct. In the alveolar section, we have these things called acini, which are kind of these grape-like clusters of cells. And then we have stem cells that are at the very end of these ducts. The stem cells produce a sebocyte, which is filled with sebum. The sebum starts to enlarge and enlarge and enlarge and enlarge and enlarge until finally it pops, it bursts. And that's going to release the sebum into the alveolar duct, then into the central duct, then it's going to eventually be released onto the surface of the skin. So it's secreting via holocrine secretion. And this is exactly what your meibomian glands are doing as well. This is the concentration when it comes to sebum, the composition of sebum. So it's composed of many different things. It's complex: triglycerides, wax esters, free fatty acids, squalene, cholesterol, diglycerides as well. And you can have problems where you're producing too much sebum or you're producing not enough sebum, just like we see with meibomian gland dysfunction. For the sake of time, I'm not going to go into all of these details, but dermatologists, they use something called a Woods lamp that they are shining light on the face. They're trying to detect if you're having too much sebum production or any abnormalities in the sebaceous glands too. So it's kind of like essentially the closest thing we have to that is meibography. So sebaceous glands are trying to lubricate the skin and the hair. It's trying to maintain a waterproof barrier. It contributes to thermoregulation, so it insulates the skin. It's involved in androgen or testosterone synthesis. It contains antioxidants, has anti-inflammatory properties to it. There's also antimicrobial properties. And then we talked about the concept of pH earlier. So sebaceous glands are contributing to the acid mantle. So are meibomian glands. That's the concept that you're trying to create a slightly acidic environment, and that acidic environment is trying to inhibit pathogens from growing. Sebaceous glands know how much to secrete based off certain properties throughout the body, primarily the secretions of testosterone. So your systemic testosterone levels are the primary regulators of sebaceous gland secretions. We see that sebum production increases at puberty and then slowly declines with age. But we see other things affect sebaceous gland secretions too. Things like high glycemic index foods and dairy will increase sebum production. If we're stressed, it can upregulate sebaceous gland production too. And then certain medications will decrease sebaceous gland function. So this is a graph of sebum-related changes over time. We see that when you're first born, you have a huge spike in sebaceous gland activity that drops off very quickly. We see sebaceous gland production increases around puberty. So that's kind of when you start to see acne because you're getting this extra sebaceous gland activity, then those glands become clogged. Then the bacteria that's on teenagers' face, because teenagers are disgusting, leads to then those glands becoming infected, and that's how you get acne. And then we see that sebaceous glands decrease their production over time. For men, you essentially reach near zero at about age 70. And then there's a sharp drop in perimenopausal women. So you end up losing, I believe it's something like 80% of your sebaceous gland secretions within a 3-year period if you're a woman that's perimenopausal. This is why we see MGD for women that are perimenopausal. So when it comes to sebaceous gland disorders, we have conditions like acne, which we've talked about a little bit, seborrheic dermatitis, which is kind of associated with fungus and overactive glands. We have rosacea, which we've talked about, inflamed glands causing redness, swelling, and pustules. Then you can have things called sebaceous gland hyperplasia, which is pictured here. It's kind of when you get just kind of these large lumps that are present on the face, and that's just an enlarged sebaceous gland. Now, moving on to meibomian glands. So meibomian glands are sebaceous glands. They're a type of sebaceous gland called a free sebaceous gland. The best way to think about a meibomian gland is it is a hair follicle without the hair. That's exactly what it is. You have 30 to 40 meibomian glands in the upper lids. You have 25 meibomian glands or so in the lower lids. If you think about the anatomy of the upper lids are way longer than the lower lids. The lower lids are pretty short. The upper lids have to be able to cover the entire eye whenever you close your eyes. So these are very, very long glands. They're long glands, they're skinnier glands, and there's a lot more of them. So when we think about the meibum secretions onto the ocular surface, you actually, about 2/3 of those secretions are coming from the upper glands, and about 1/3 are coming from the lower glands. In general, meibomian glands are smaller than sebaceous glands. They have lower volumes of secretions, but more secretory acini. And then it's believed that meibomian glands secrete through the compression of the muscle of Riolan. So the muscle of Riolan is part of the orbicularis, and when you blink your eyes, it compresses the meibomian glands via that muscle of Riolan that is believed to facilitate expression of the meibum onto the ocular surface. So in general, if we are comparing meibum compared to sebum, there are clear differences between the two. So meibum is far more complex than sebum. There's over 600 different types of lipids in the meibomian gland secretions alone. There's way more protein in meibum compared to sebum, over 90 different types of proteins in meibum compared to sebum. There's way more types of keratin, which actually ends up leading to being problems for our patients, which we'll talk about in a little bit. And meibum actually contains polar and nonpolar secretions compared to sebum, which only contains nonpolar secretions. We actually need these polar secretions in the meibomian gland secretions because if we didn't have them, there would be nothing that would help the lipid layer of the tear film adhere to the aqueous layer of the tear film. So by having these polar components of the meibum, it actually facilitates interaction between the aqueous and the lipid layer. So the lipid layer doesn't just fluff right off that aqueous layer. So it's very important that we have that. There's longer chain wax esters in meibum compared to sebum. Meibum is a lot more viscous than sebum, which means that it helps more with evaporation. And there's also way higher levels of antioxidants and anti-inflammatory components in the meibum compared to the sebum. So in general, meibum is far more complex than sebum, more antioxidants, more anti-inflammatory aspects, and it's really tailored specifically to the ocular surface. So it's more complex, it spreads better on the ocular surface than sebum would. It's going to help with reducing evaporation better than sebum would, and then again, higher antioxidants. So this brings us to poll question number 4, comparing meibum to sebum. I think this might be one of the harder questions of the day, but which statement is false? So which one is false? Meibum contains both polar and non-polar lipids. Meibum has fewer antioxidants compared to sebum. Meibum contains a greater number of unique lipids as compared to sebum. Meibum is more viscous than sebum, or both meibum and sebum contribute to an acid mantle. I think this is probably the hardest question.
This is the another boards question here.
Right.
And you're caught up on the questions. We're all good.
Good.
Well, we've got the trend rolling in here. The answers are rolling in slow, but I think everyone's rereading it, trying to make their best.
Yeah, I may have made this one a little too complex. Especially because it's not something we think about ever. In eye care, we're not really thinking about sebaceous glands much, or sebum in general.
So I'm gonna go ahead.
I was gonna say that, I mean, the point of this is to really show how meibum, even though meibomian glands are sebaceous glands, that meibum is really tailored specifically to the needs of the ocular surface.
Yeah, so I think the key here is when you start getting meibomian gland dysfunction and there's meibum and those glands that are dysfunctioning, it quickly leads to the evaporation, if you want to say, of the ocular surface and leads to the dry eye issues. So and really I mean, maybe other than Meibo that's out there trying to help out with that, I mean, really it's really best to replace it with the most, like a car part. It's the original car part. It's not always best to replace it with something else. So trying to keep everything healthy is kind of, I think it's kind of why we want to discuss this. So
and
answer
we'll talk about one drug that is coming out probably in 2027 that I think will be a game changer for MGD.
And we have 45% going with B, and we have 25% going with D. So if you want to go through your answers.
Okay. Yeah, so the correct answer is B, because meibum actually has more antioxidants compared to sebum. It's trying to provide a lot of anti-inflammatory support to the ocular surface. Meibum is actually more viscous than sebum. That is a true statement, because the increased viscosity ends up helping prevent evaporation a little bit better. All right, so now we're going to compare meibomian gland dysfunction with sebaceous gland dysfunction. We're going to do this comparing what's happening in terms of pathogenesis, and then we're going to go over, kind of in the last part of this talk, kind of the similarities between treating sebaceous gland dysfunction and meibomian gland dysfunction, where it's the same and where it's different. So in general, when it comes to sebaceous gland dysfunction, this is diagnosed way earlier than MGD. The reason is because there's visible skin changes. Patients look at themselves in the mirror every single day. They see what their skin looks like. If you start to get pimples on the skin, if you start to get clogged sebaceous glands or lesions or papules or pustules or changes in your cosmesis, patients see this immediately they're bothered by it, they go and they see a dermatologist and they try to get it fixed. So sebaceous gland dysfunction is diagnosed very, very early, just by a clinical exam, oftentimes diagnosed by a patient. When it comes to MGD, patients aren't looking at their lid margins. Patients aren't averting their eyelids to look at what's happening with their meibomian glands. So in general, early signs of this are not visible to a patient. Early signs of this are oftentimes not even really visible to practitioners. So not all of us have meibography. We're not seeing the atrophy that's happening. We're pushing out the glands. We're seeing if they're secreting, but we don't know how long those glands are, or how many glands they actually have. So meibomian gland dysfunction is oftentimes kind of a hidden progressive condition, whereas sebaceous gland dysfunction shows obvious skin signs that are diagnosed early on. So when it comes to healthy meibum, it should be clear. It should have a melting point that is below that of body temperature. So your natural eyelid temperature should be enough to keep the meibum flowing onto the ocular surface. It shouldn't be thickened. The eyelid temperature should be able to melt it. You should need a warm compress. It should help reduce friction between blinks, lubricate the surface, retard evaporation. It's anti-inflammatory and antimicrobial. But when you get unhealthy meibum, it's difficult to express. It's thickened. You get these keratin aggregates. You get elevated melting point, poor spreadability. It doesn't help reduce friction. And that matters because we're blinking about 15,000 times a day. If we don't have meibum there to smoothly help that upper lid blink over the globe, and you start to get some friction, that can cause a lot of damage to the ocular surface. So unhealthy meibum has an altered microbiome and it's pro-inflammatory. So the picture here is of a patient of mine who's an Uber driver. This patient could only drive for Uber for about 3 to 4 hours before his eyes bothered him so much that he just had to stop. And this is bad because it's his source of income. And so whenever I went to go express his glands on the first day, I was pushing hard. I literally could get nothing to come out of any of his meibomian glands. This is him immediately after I did meibomian gland probing on him without me doing an expression. So I actually probed those glands and the meibum just burst straight out of those meibomian glands without me actually expressing the glands at all. So there was so much pressure that was built up inside that gland that kind of when doing the probing, it just released all of that pressure and it just flowed right there onto the eyelids. So when it comes to meibomian gland pathophysiology, there's hyperevaporation. So we know that the tears are going to evaporate too quickly because you've lost that lipid support that prevents evaporation. When those tears evaporate too quickly, there's less tears that are physically present on the eye, but the salt content remains. So you get this hyperosmolarity. You get inflammation, obstruction, and altered microbiome, and hyperkeratinization. We're going to break each of these down. So with hyperevaporation, quantitatively, maybe you have physically less glands. If you physically have less glands, they're not secreting very well, but there's not as much that's secreting. But qualitatively, even you can have hyperevaporation that's happening just because you have differences in compositional changes of the lipids. So if you start to just get poor quality meibum, that is going to lead to hyperevaporation. You can essentially become meibum deficient, which is not a term that anyone uses, but it's really what's happening in these cases. And then if you're not getting those polar lipids that are supposed to be in the meibum, you don't have the polar lipids to anchor to the non-polar lipids that helps stabilize that tear film. So you can start to get changes in the composition of that meibum. The sebaceous gland dysfunction, the SGD, parallel to this, is if you get lipid barrier dysfunction, then you get water loss and you get inflammation of the skin. When it comes to that hyperosmolarity, so some people like to think of dry eye kind of as an equation. They think if your tears are evaporating quicker than they're being produced, then you have dry eye. And I think that there's a lot of truth to viewing dry eye like that. If your tears are evaporating too quickly or not replenishing the aqueous, the salt content remains in the tear film, but there's less tears that are present. So you end up getting this increased osmolarity. When you get increased osmolarity, this triggers problems in our patients. This leads to inflammation. It promotes goblet cell loss. It's linked to neurosensory dysfunction, inflammation. The sebaceous gland dysfunction parallel to this is when you start to get stress on the skin due to that hyperosmolarity. We start to get inflammation of the meibomian glands and in the meibum itself. So you start to get inflammatory cytokines in the eyelid tissue, meibomian glands, tear film, The meibum, it disrupts meibocyte function and leads to oxidative stress and surface damage. The sebaceous gland dysfunction parallel to this is that you get similar cytokines in lipid-driven inflammation in conditions like acne and rosacea. And then if you get obstruction, so obstruction is important. This is about 80% of meibomian gland dysfunction. There's obstruction. So you get this hyperkeratinization. And so this is keratinization that can cover the meibomian gland orifice, so it can't actually secrete well, like you see in the patient there on the right that I described earlier when we did probing, and all of a sudden the meibum just kind of flowed right out. So you can get keratinization that covers the orifice. You can also get keratinization in the gland itself. And this will lead to thickened meibum. It'll block the glands. It leads to stasis. When that happens, you start to get pressure that's happening inside of the gland. That pressure is going to lead to the gland dilating because the gland is now stretching because there's so much pressure in the gland, but there's nowhere for the meibum to go, yet the meibum is continuously produced. So it leads to tortuous-looking glands, atrophy, fibrosis, and dropout. So the sebaceous gland dysfunction, the SGD parallel to this, is that you get similar gland blockages, dilation, and loss of sebaceous glands, like in conditions like acne and rosacea. Then you can get altered microbiome. So you can start to get a shift from commensal bacteria to harmful bacteria. You start to get those lipases that break down the meibum. So you see evidence of saponification in this picture here. That's the frothiness of that tear film. Anytime I see frothiness of the tear film, I'm pretty much always recommending a hypochlorous acid spray to my patients. One of the attendees kind of mentioned earlier, it can be helpful in ocular rosacea. So when you get this microbial dysbiosis, it's not just a bacteria, though. You can start to get increased Demodex folliculorum and brevis that infests the follicles and the glands. So this leads to recurrent hordeola, Schlesias styes, lash abnormalities, refractory blepharitis. The SGD parallel to this is you can get similar imbalances of bacteria and Demodex in acne, seborrheic dermatitis, and facial rosacea. Now, one thing I really want to cover is the concept of keratinization, because I think it's something a lot of people don't know much about and don't think about, but it is a giant problem in meibomian gland dysfunction and sebaceous gland dysfunction. This is the excessive formation and accumulation of keratin. You get these aggregates that are present inside these sebaceous glands, just like you get them present inside the meibomian glands. So it can cover the duct, the orifice, or be within the glands. And then what's worse is you can get keratinization in the meibum or sebum itself. This is triggered by oxidative stress. It's this and then you get these aberrant disulfide bonds that are forming between keratin molecules. Why is that a problem? Because when you get these disulfide bonds, it increases the viscosity of the meibum and the sebum. It makes it harder to express, and it impairs the spreadability. So when we get this hyperkeratinization in the skin, it causes acne, seborrheic dermatitis, and rosacea. You get the formation of plugs. It affects the gland appearance. It induces inflammation, facilitates microbial growth, causes skin irritation. But the exact same thing is happening in the eyelids as well to our meibomian glands. You start to get altered meibum quality, higher viscosity. It's got this waxy texture, increased thickness. It causes stasis. It plugs up the glands, and it looks like blocked glands, like you see in that picture there. And this can lead to gland stress and eventual atrophy of those glands. It's the exact same process that's happening here. And this can happen even with just a 10% increase in keratin. You can start to get this increased surface pressure, rigidity, a dilated central duct. It plugs up the gland. And then another thing it does is that it raises the melting point of the meibum. So we've probably all had patients that you diagnose them with meibomian gland dysfunction. You say, okay, go home and do warm compresses. You've got this thickened meibum. We're going to try to melt it. If we melt that meibum, it's going to flow better. It's going to help your MGD. The patient comes back and they say they've been doing their warm compresses. You go to express the glands. It's the exact same. It's thickened, it's turbid, it's inspissated. And you're like, are you sure you've been doing the warm compresses? They say, yeah, I've been doing it 10, 15 minutes a day. You say, are you getting it hot? They say, yes, I'm getting it really, really hot. So why does that not work? Well, if you get this increased keratin aggregates inside the meibum, it can actually raise the melting point of the meibum as high as 275 or 300 degrees Fahrenheit. That's way hotter than a warm compress can touch. Now that's an extreme example, but it's not uncommon that you get the melting point of the meibum to be 140 degrees. If you've got a warm compress that's maybe 120 degrees, 125 degrees at most, and you're putting it on the eye, you're not going to be able to touch a melting point of 130 or 140 degrees. So this is why warm compresses, theoretically, we think they should work in patients, but they don't, because the melting point is too high in these cases of turbid meibum, where the meibum quality is so poor that the melting point is very high. So in those cases, you're kind of wasting your time if you're trying to do warm compresses in those patients. And even radio frequency has a hard time with that because it's hard for radio frequency to end up kind of melting those waxy plugs, although it's much better than warm compresses are. So let's talk about keratolytics. Can we come up with a drug that could break down that keratinization? This has been used in dermatology since the 1950s. It's used in all different types of sebaceous gland disorders, like the ones listed there. The effects of keratolytics is that you can regulate sebum production, loosen those sebum plugs, shed dead epithelial cells, remove buildup in the follicles. There's anti-inflammatory effects. It reduces acne severity in terms of lesion frequency and severity. It normalizes collagen production and sebaceous gland function. So this is a drug, AZR-MD001, that is positioned to be the first and only pharmaceutical therapy indicated for the treatment of meibomian gland dysfunction. And it is a keratolytic. So it's really doing three different things. The first is it's a keratostatic. So it decreases keratinization that's happening on the meibomian gland orifice and in the duct itself. So if you decrease that keratinization, you're helping with obstruction. It's a keratolytic, so it breaks apart the keratin aggregates in the meibum. When you break up those keratin aggregates, you lower the melting point of the meibum. When you do that, all of a sudden you don't need warm compresses anymore because the natural temperature of the eyelid is enough to keep the meibum flowing onto the ocular surface. And then the third thing is it has lipogenic effects. It increases the maturation rate of those meibocytes. If you're increasing how quickly the meibocytes are being produced and then bursting into that alveolar duct, you can increase meibomian gland secretions. So this drug is finishing phase 3 clinical trials right now. One nice thing, it's an ointment that is dosed twice weekly. Instead of twice daily, you put it on the eyelid margin just twice a week. And patients have tremendous benefits even after only 4 applications of this drug. The FDA decision should be sometime next year and probably commercially available in 2027. So how can we treat meibomian gland dysfunction like it is a sebaceous gland dysfunction? When we look at sebaceous gland dysfunction, when we look at meibomian gland dysfunction, there's a lot of shared therapeutic goals. We're trying to normalize lipid secretions, improve gland outflow, reduce inflammation, address keratinization, and modulate the microbiome. We're trying to do a lot of different things. So when it comes to anti-inflammatory aspects, this is happening of the face and the meibomian glands. We can use things like cyclosporine, lifitegrast calcineurin inhibitors for MGD. That's also used in sebaceous gland dysfunction. Corticosteroids are used in MGD and SGD. When it comes to the bacterial and anti-inflammatory properties, so things like azithromycin is used in MGD, metronidazole is used in SGD. And then for MGD, we use steroid antibiotic combinations. And then we see that oral doxycycline and azithromycin are both used in MGD and SGD. And then we have things like perfluoral hexaloctane, that's MIBO, that we can use in cases of evaporative dry eyes, so caused by MGD, to try to stabilize that the lipid aspect of the tear film. And then the equivalent of that for SGD is over-the-counter lotions and creams. Could we enhance secretions? Well, there's 2 different drugs that are on the market right now that are immunomodulators. One goes in the nose, one goes on the eye. Theoretically, that could enhance secretions from the meibomian glands. If you stimulate the trigeminal nerve to do that, theoretically, the meibomian glands are innervated by the trigeminal nerve, and you could then end up increasing secretions. And then there's that drug coming out in 2027 that I think is going to do a phenomenal job at enhancing secretions. When it comes to diet and supplementation, a lot of this is the same thing that we saw with our rosacea patients, because rosacea causes SGD and MGD. But foods that are high in omega-3s, anti-inflammatory, prebiotics, probiotics, things like limiting alcohol consumption, sun protection in case of rosacea, prioritizing sleep. All those can be very helpful. In the field of dry eye, we have oral omega-3 supplements for MGD. There's also a supplement that contains lutein, zeaxanthin, curcumin, and vitamin D that I find works really, really well for MGD and ocular rosacea in particular. Now, when it comes to addressing keratinization, we do not have anything that we can use when it comes to meibomian gland dysfunction for this yet. When it comes to sebaceous gland dysfunction, dermatologists have been doing this for 70 years at this point. Things like salicylic acid, things like retinoids, like vitamin A. But hopefully we'll have our first keratolytic drug for eye care in 2027. Now, vasoconstrictors, we talked about this a little bit with ocular rosacea. This is used all the time for sebaceous gland dysfunction. So azelaic acid is used on the face, brimonidine gel is used on the face. Could we use brimonidine in cases of MGD, especially if there's those dilated telangiectatic blood vessels? I think yes, and I think it can work very, very well. Now, vitamin A derivatives is one area that we start to differ, I guess, with dermatology. So retinol palmitate is a weak vitamin A derivative that has been used in MGD and SGD. It's not really widely available in the United States. Things like retinoic acid, think your Retin A products that are used on the face, your retinoids, there's over-the-counter ones, there's prescription ones. That's very helpful for sebaceous gland dysfunction. And then there's oral isotretinoin. So that's like the strongest synthetic form of tretinoin. And that's called Accutane, and that's used for sebaceous gland dysfunction. We do not use that for MGD. So this is where we start to diverge from dermatology. So you might say, well, in dermatology, we try to actually decrease sebaceous gland secretions. We're trying to do that because when you have too much secretions, you get greasy skin, you get oily skin, you also start to get clogging of those glands. And in general, when it comes to dermatology, if you dry up the skin, it isn't as bad as the effects of an overactive gland that keeps getting clogged. In general, that's true. So that's why dermatologists try to decrease sebaceous gland secretions. However, when we decrease meibomian gland secretions, it causes massive problems in our patients. It causes a lot of discomfort. So why would it cause discomfort for the eye, but not the skin? Because the cornea is about 300 to 600 times more sensitive than the skin. We have 8,000 nociceptors, or nerve endings, per square millimeter in the cornea. So it's the most densely innervated tissue in the entire body. So small decreases in meibum secretions lead to a lot of discomfort. Whereas the skin, you can dry out the skin without the skin really, really bothering patients before, if there's little changes there. And in general, dermatology would rather have a sebaceous gland secreting less than a sebaceous gland secreting more. Whereas for eye care, we would rather have a meibomian gland secreting a little bit more than not secreting at all. So it has to do with differences in sensitivity of the skin versus the cornea. So then we have things like other options like testosterone cream. I do a lot of compounded testosterone cream that I have patients put on their eyelids because we know testosterone stimulates sebaceous glands, including the meibomian gland. So if you stimulate the meibomian glands, you can lead to an increased production of meibum, which can help with MGD. But we don't see this with sebaceous gland dysfunction because we're not really trying to increase secretions in those cases. When it comes to mechanical and thermal therapy, there's things like thermal pulsation for MGD, meibomian gland probing for MGD. Expression is actually done for MGD and sebaceous gland dysfunction. And then we use low-level light therapy for MGD and SGD. And we also use IPL for both conditions. So this is kind of a breakdown of all the different light therapies done for sebaceous gland dysfunction. So you'll notice the first 3 are done for MGD, but the last 5 are not done by optometry or ophthalmology a whole lot. So we use IPL. We do it to seal off those unhealthy blood vessels of the eyelids. We do it to regulate sebaceous glands, to mitigate microbes, to reduce inflammation. And we find that's very helpful for dry eye, for MGD, and for ocular rosacea. You can use low-level light therapy with red light, which is supposedly activates meibomian or mitochondria. It is anti-inflammatory, modulates the glands, promotes healing, cellular repair. That's the theory behind it. Then there's blue light used in low-level light therapy that is supposedly antimicrobial. It is supposed to help with kind of the bacterial component and the microbiome component of the face and the eyelids. All of these other light and lasers, though, we do not really use a whole lot in eye care. That's used more by dermatology. Then when it comes to hygiene, this is hygiene like wipes is used for MGD and SGD. Hypochlorous acid sprays are used in MGD. We do blepharoexfoliation for MGD, but for SGD, they're usually doing chemical peels, more lotions and creams, cleansers, shampoos, and serums. And then we do warm compresses. Dermatology doesn't generally have, you do warm compresses of the face. So this is where MGD and SGD treatments diverge. Oral isotretinoin, so that really, really strong vitamin A derivative used to decrease sebaceous gland function. This will diminish sebaceous gland secretions by 90% within 6 weeks. It does that of the face, but it also does it of the meibomian glands. This is why it causes severe MGD and accentuates dry eye. Topical retinoids are used all the time on the face. It's not recommended to get these anywhere near the eyes. I'm in the middle of a 3-year systematic review that we're exploring topical retinoids used around the eyes, trying to figure out if it harms meibomian glands. And in general, we find that it does increase harms to the eye. Hormonal therapies. So we do kind of testosterone cream on the eyelids. It's not really used a lot in sebaceous glands. Comedo extraction, that's kind of like where you're strategically popping pimples. That's done in SGD. For MGD, the closest thing we have to that is really meibomian gland probing. Not a lot of people do probing, though, and it's not a very fun procedure to do, in my opinion. And then chemical peels, you can do that of the face. You can't do it of the eyelids. It's way too harsh to do on the eyelids. It's very abrasive. It would be very uncomfortable. So the last poll question that we have of the evening is this one here. So which of the following treatments may be beneficial for sebaceous gland dysfunction, but may actually worsen meibomian gland dysfunction? So choice A is retinoic acid or tretinoin. Choice B is intense pulse light. Choice C is topical or oral antibiotics. And choice D is calcineurin inhibitors such as cyclosporine.
And you're all caught up on your questions.
Oh, great.
All right, the polls are rolling in. Give it a minute or two or a few more seconds, maybe not a minute. Okay, we'll display the results here, and clear winner at 85% is A with retinoic acid, and then everything else is 9% right down the line, or 10% now, intense pulse light. Topical or oral antibiotics are 6%, and your calcineurin or your cyclosporin is 2%. So A is 80%.
Oh, good. Yeah, so that one, we all have heard of Accutane causing MGD. The active ingredient in that is isotretinoin, so it's actually a synthetic form of tretinoin. The hard thing when it comes to vitamin A derivatives, and I think we've got some time to discuss this a little bit, is that there are so many different forms and they're all different strengths. So we have beta carotene, which is at the bottom. This is what we eat, like in things like carrots, and we take supplements. Then the next level up is retinol palmitate, like these retinol esters. That's about 100 times stronger than beta carotenes. Then up from that, we have retinals. So these are like retinaldehydes, which is oftentimes used like in topical skincare products. That's something like 10 times stronger than retinol esters. Then we have retinoic acid. That's 100 times stronger than the retinals. that is what is in general a prescription, like Retin-A's that patients use on their face. If you get that near your eyes, we know that that damages meibomian gland, but we think it is reversible. Then you get to synthetic forms like adalapine, and there's some other options like the isotretinoins. That is like 100 times stronger than retinoic acid. So if you go from the bottom ones to the stronger ones, there's like a 10,000 or 100,000 fold difference in strength. It's unbelievable, how much stronger these get. So the hard thing is we don't know what the cutoff is. Can you use a retinol ester around the eyes, and is that fine? We think probably so, but at what level, at what strength does it start to become a problem? And that's what we don't know, and that's what my research group is actually trying to figure out right now. But I'm not sure if we'll be able to come up with the answer for that, but we're trying. Okay, so these are the shared therapeutic goals, again, between MGD and SGD. We want to normalize lipid secretions, improve gland outflow, reduce inflammation, address hyperkeratinization, and modulate microbiome. The biggest difference is that SGD, oftentimes you don't necessarily want to increase secretions. You can improve gland outflow, but you're trying to do that so the glands aren't clogged. In MGD, it's really, hyposecretions form of MGD is a lot more common than hypersecretion. Hypersecretions can be a problem, definitely. But in general, when patients have MGD, typically they are meibum deficient as opposed to having too much meibum. So the final takeaways that I have for this section of the talk: don't think about the eye just in isolation from the body. There are so many similarities between MGD and SGD. In general, when we think about the eye in relation to what's going on systemically, it gives us a lot better diagnostic insights, and we can come up with more logical treatments for our patients. And unfortunately, eye care, we're about 50 to 70 years behind dermatology in a lot of our treatments, but I think we're hopefully going to catch up sometime soon, or at least start kind of regaining some ground here. We need to ask why the MGD is occurring, and then we can get creative with our treatments. We can look to our dermatological colleagues, see what they're doing, and this can give us insights in how we can better help our patients. These are my references. These are some pictures of my family. I've got a 5-year-old daughter, and I have twin 1-year-olds right now. There's some pictures of them. And then that's my email address if anyone wanted to send me any emails with questions after the presentation.
I want to
Thank
make
you very
one
much.
I want to make one comment. It was a fantastic lecture. It was awesome. Drinking out of a fire hose, but that's why we brought you to OEC, because we know that you can do that to us. But what I like to point out to the audience is that in this kind of functional way or disease management is that we always kind of think linear, right? So, we have this, let me try azazite. So what it might be a combination. This is, acute disease is very linear binary. If you have a corneal abrasion, we all could probably agree upon, a bandage contact lens. You might argue antibiotic versus antibiotic steroid. But we're all gonna have something similar. We're gonna kind of have an acute treatment that would probably most of us could agree upon. When it comes to chronic disease, whether it's diabetes, thyroid, or now ocular surface disease or meibomian gland dysfunction or rosacea, don't be linear. Let me try this or that. It might be a combination of things that Kaleb discussed. So you might be picking 2 or 3 things, and maybe you can expand upon that, Kaleb.
Yeah, I think that's a great point. And I think, yeah, we've thought about dry eye and ocular surface disease so linearly for such a long time. We say, if they come in with these symptoms, we're going to start them on artificial tears or warm compresses. That doesn't get better. We're going to try this. If that doesn't get better, we try this. We're starting to know enough about MGD, enough about ocular surface disease, that we can actually tailor our treatments a little bit better than we used to be able to. So, I encourage you to go out there and to try to, when you're evaluating MGD, really do the things like corneal staining, tear breakup time. Really push on the lids. Try to see, are they secreting, are they not secreting? Even if you don't have a meibographer, you don't necessarily have to have that to be able to tell. You can hold up a transluminary and you can see, is there so much atrophy of the glands that there's no glands there at all? Are there any glands secreting? And then, try to think strategically about what's going on. Like if you're trying to figure out, should I use an oral antibiotic in this case? I mean, is there saponification? Is there blepharitis in MGD? In which case, do they get bacterial conjunctivitis cases? Are there flares? Like oral antibiotics can be helpful in cases like that. You kind of just have to think a little bit strategically and then try to tailor your treatments a little bit towards kind of what you're seeing clinically. But very often, it's not going to be one thing. There's not going to be one thing that's going to solve these patients' problems. You have to have a combination of these. And then you tell your patients it's, this is a dry eye journey, an MGD journey that we're embarking on. It's going to take us a little bit to figure out, exactly what works best for you. So one thing I always do before my dry eye patients leave the room is I tell them, if this doesn't work, don't lose hope. We have so many other things that we can try. And then I even in my exam notes, I have a future consideration section and I type in all my future considerations because it gives patients hope when you do that. Kind of if you say, if you're not better in 2-3 months when we see you again, don't worry, we have other options. Like the patients, if they're not better, they're not discouraged. They come back and they're like, oh, my eye doctor has other options and things that he's already thinking about or she's already thinking about trying with me. So kind of give them hope and let them know it may take a few visits for us to figure out what works best for you.
Fantastic. So a good way of saying it is think of it as a strategy that's out there whenever you're working with these patients. So, all right. So you see right here, that little red dot has popped up. Please start that survey, or you can wait another 7 minutes to get it via email. And Joe, I'm going to let you see if there's any questions that have rolled in.
No, there are no questions. We're all caught up. But Kaleb, I want to thank you for doing this. It was a great lecture. I was jotting down a number of things that were very helpful to me, so I really appreciate it. Thank you so much, and I think our audience will
Thanks,
appreciate
Joe.
it as well.
Okay, so if we're caught up on questions, I will say, okay, thank you. This was Sebaceous Gland Link, integrating dermatology into rounds of ocular rosacea and meibomian gland care. This was a synchronous virtual course. Kaleb, thanks for a fantastic presentation. This will conclude the education for tonight.
Thanks, Greg.
Yep.
Have a good evening, everyone.
Thank
All
you,
right, bud.
Kaleb.